Good evening, ladies and gentlemen. Thank you for coming. I'm a Chief International Officer for Apromed Medical Education. We are an education institution with academic management of 18 years of experience in medical education. Our mission is to provide high-quality education to our doctors so that our students can expand their knowledge and improve their diagnosis. Today, we are going to talk about lung transplantation, and I'm honored to present Dr. Rafaela Ribeiro, PhD from the University of Toronto, Canada, studying lung transplantation and infectious disease, ex vivo lung perfusion specialist assistant at Toronto General Hospital, Canada. So thank you very much, Dr. Rafaela.
Hello, good night. Thank you very much, Gabriela. Thank you very much, Apromed, for this wonderful invitation to be talking to you all tonight about a really nice topic. I'm a bit biased, of course, because my PhD is in lung transplantation, but I think this is a nice topic, and I'm talking directly here from Toronto in Canada, where I've been here for 5 years doing my PhD, my research in lung transplantation, and most importantly, being exposed to new technologies every day here and a lot of novelty around this field. And Toronto is a huge center for lung transplantation, and it's recognized all over the world. So again, it's a pleasure to be here. And I'm just going to share my screen here so I can show you a few things. So yeah, thank you again. Good night, everyone. Good night for those that are accessing us from Brazil. I know tomorrow is an important holiday for us in Brazil, so thank you for taking your time to study a bit of something different tonight. And I promise that after here you can go have a nice cocktail, since tomorrow you have a day off. Okay, so I just want to start out by saying I have no disclosures. And I'm going to talk really briefly about myself. So I am actually a medical doctor from Brazil. So I graduated in 2016 from URGS, so South Brazil, Rio Grande do Sul. In July of 2017, I moved to Toronto to start my PhD. So September, I started as a master's student, but then I migrated into a PhD program. In July of 2019, I was part already of the ex vivo lung perfusion clinical team here at the Toronto General Hospital. I'll explain a bit more about the ex vivo lung perfusion for you guys soon. And today, I'm happy to say that I defended my PhD. So I'm officially a PhD in lung transplantation, and I'm extremely happy with this accomplishment and extremely happy to be here today already talking about this this field that now I'm considered quite an expert. So it's really nice. So want to start saying that Toronto General Hospital was elected within the 5 world best hospitals in 2022. And this is a study that includes all the hospitals in the world. So it's a huge center. And I think one thing that's really important of the Toronto General Hospital, and that actually drives the hospital into being a world within the 5 best hospitals in the world, is actually its transplant program. Okay, so this is a bit outdated. It's from May 2019, but it's before the pandemic. So with the pandemic, things got a bit slower everywhere in the world, of course. So I think this is good data anyways to show. So in May 2019, Toronto General Hospital performed more transplant than ever in their history, where 76 patients received a total of 81 organs. So this is quite an accomplishment. And I think I'm bringing this just so you get a nice understanding of the importance of this center here in Toronto for not only lung transplantation, but transplantation in general, and not only in Canada, all around the world. So I think another really nice opportunity here today is to tell you guys about this lung transplantation course that we are planning really carefully for you guys, for the ones that are interested in knowing in much more details about lung transplantation and everything that's new around this topic and what we've been doing here in Toronto. So this course will take place in 2 Saturdays, 2 Saturday mornings, so September 17th and September 24th. And I'll just go quickly through the topics that we will discuss during the course. But of course, we would love you to join us for this course and to be able to get a more detailed understanding of lung transplantation in general, and again, all the novelty we'll be doing. So for the first Saturday on September 17th, we're going to start by talking general indications and inclusion criteria for lung transplantation. Then we're going to move on to talk about the types of lung donors and the selection criteria for these donors, because this is a really critical thing. So the donors, the type of donors and how you select your donors, they can have really important implication, positive and negative implication after a transplantation. So this is an important topic. Then we're going to move into talking about a bit more specifics of the surgical technique involved in this technique. So since the retrieval until preservation of the organs and the actual transplantation. So we're going to talk about more in detail of the surgical techniques. And the last topic for the September 17th day, we're going to talk a bit more about after transplantation, what happens, right? So immunosuppression, we know it's really important for patients not to reject the organ that they are receiving. But we know that doing immunosuppression, we do have a lot of problems in an acute phase, but also in long terms. So I'm going to talk a bit about the challenges that we have with this immunosuppression and what results from this. On the second Saturday, on September 24th, we're going to talk more about this novel platform that I've been working for the past 5 years here, which is the ex vivo lung perfusion. So the first topic will be really to introduce and to go into deep of what is this new technology for organ preservation and evaluation. And then we're going to talk about how we can use this platform of the ex vivo lung perfusion to actually improve diagnostic and treatment of this donor organs even before transplantation. So it's quite interesting. And then we're going to talk about something that has been done in the last year and a half, I think, here in Toronto, which is a really game changer, which is changing the preservation temperature of lung donor organs to 10 degrees. So normally it's 4 degrees. That's what's been done since 1983. And in the past 2 years, we here in Toronto, we studied preserving this donor organs at 10 degrees. And what we found is that it actually improves quite substantially the quality of the organs, and it reflects in really good post-transplant outcomes. And I think the most important novelty here is that it actually allows for a longer preservation. So transplantation of organs usually happens at any time of the day, or even usually 2 a.m., 3 a.m., right? And by preserving these organs at 10 degrees, we actually have the opportunity to just leave the organs overnight. So let's say from 6 p.m. to 6 a.m. the other day, and we're able to start the transplant procedure early the next morning. So you have the surgeons, they have a good night of sleep and they come fresh for the transplant. So this is a really nice topic that we will discuss as well. And then lastly, we're going to talk about, I think, something that was really important in the last few years, as you all know, which is the COVID-19 pandemic. And actually lung transplantation came into place here in Toronto. We did a few lung transplantations as kind of like a salvation procedure for end-stage COVID-19 patients. And in other places of the world too, and mainly in the United States. So we're going to talk a bit about that too. So we invite you guys to join us for this course. I think it will be really nice. We're going to go into detail into detail of all of this really nice topics. And there's actually one curious thing that I haven't mentioned before, but actually the first lung transplant ever, the first successful lung transplant performed was actually here in Toronto in 1983. So that's a curiosity, but that actually shows that this center here in Toronto for lung transplantation, since back in the day, since the first lung transplantation up to today, it's been a high level quality center, and people all around the world actually respect the Toronto practice here because of that. So I wanted to talk a bit briefly, of course, because during our 2 Saturdays, we'll have the opportunity to talk in more details, but really briefly, just to give you a bit of a taste of what I've been doing in the last years here, which is this normothermic ex vivo lung perfusion, so the EVLP platform. And really how this came into place back in 2008 and why it's so important nowadays for us here in Toronto and in a lot of other places in the world. So lung transplantation, it is a life-saving procedure for end-stage lung diseases, but there are still major obstacles for this procedure to be a success. And one really, really important thing is the absence of sufficient organs to meet the growing demand of patients that actually need a lung transplantation. And because of this absence of sufficient organs, the wait list mortality, so basically patients that are waiting for the organs and are never called in for the actual transplant, is as high as 30%. So there's a 30% mortality of the patients just by waiting on the wait list. And this happens because transplant teams, they are very conservative with selection criteria of these organs due to the risk of primary graft dysfunction. So basically, early after the transplantation, the body rejects the graft. So that's the major fear of transplant teams. And that's why a lot of teams are quite conservative when selecting or lung donors. And because of this, what happens generally is that, let's say you have a donor offer in the ICU, and upon this donor offer, the lung transplant team will evaluate this donor and decide whether it's okay to go ahead with the organ procurement, right? But just at the donor offer, a lot of organs are already declined. So let's say you have 100 organs offered, about 50 or a bit more are declined even before going into the surgical center, opening up the patient and looking at the lungs. And let's say another 50%, another 50 goes for the organ procurement, and there's more declination of some organ donors. So overall, there's a decline of 80% of offers, which is quite a bit. So let's say only 20% actually go ahead. And when going ahead, after you take out this lung from the donor, you basically put it in cold static preservation, which is a preservation at 4 degrees. And only then 20% actually go for transplantation. And I mentioned before, so this cold static preservation, which is the gold standard since 1983, so since the first transplant performed here in Toronto, and up to 2016, kind of. And what is the idea, and it's still pretty well accepted today, of preserving organs at 4 degrees. And basically, it's like you see here in this image. It's just putting the organ inside an ice box at 4 degrees. It's really straightforward. So in that sense, it's good. It's cheap and straightforward and easy to do. And the idea is that at 4 degrees, the cellular metabolism is reduced to about 5% of the normal metabolism. And why that's important, and it's seen as protective, because you basically you slow the possible injurious processes. So basically cell death, necrosis, and this all, if you have a lot of this processing happening, you have a lot of damage to the organ. So the idea of 4 degrees is actually stopping all of this process. However, a major problem with this type of preservation of basically putting a lung inside a box at 4 degrees is that it's as the name says, it's a static preservation. So injured organs cannot be actively improved or repaired. So a solution that came up here in Toronto around 2008 was using this EVLP, the ex vivo lung perfusion. And what's nice about this, so I think you can see my video here, and this is a real EVLP happening in our OR here in Toronto, okay? And the idea is that basically you get this donor lung that you're not quite sure of the quality, and you put it inside this, this box. And you can see here we connected to endotracheal tube, which is connected to a ventilator, an ICU ventilator. And the lung is perfused through the endothelium with cannulas through the pulmonary artery and the left atrium, okay? And the idea is that we're gonna perfuse these lungs at 37 degrees to mimic the physiological conditions, just like all of us are doing right now, right? We're at 37 degrees body temperature, breathing in and out. And this is the idea of this EVLP platform, is to mimic physiological conditions to try to restore physiological metabolism and to be able to treat possible damage to this organ. So then here you have a time frame of, let's say, 4, 6, or even 12 hours, where you can accurately assess and even diagnose possible problems that's happening. So you have the option to treat, to recover, and to repair. And after a 4-hour period, let's say, you're able to get a lot of data on the lung. You can do X-rays, you can do bronchoscopies, you can do arterial gases to be to give you more assurance of the real quality of this organ, and to safely proceed to transplantation after this assessment. And this was so important that it was actually published in the most important medical journal that we have, the New England Journal. This was published in 2011. Again, it was a clinical trial here in Toronto because this EVLP technique was developed here in Toronto. And the trial was really successful. We were able to include and transplant much more organs because of this. And after this publication, the EVLP platform started to be part of our normal clinical practice here in Toronto. So we do it weekly here, around two times a week, sometimes even more, to assess donor lungs and be sure that we have good quality lungs to proceed to transplant, to safely transplant into recipients. And we know we can never say we're 100% sure, but we'll have more success in having pretty good outcomes after the transplant procedure. So really, just like, what are the major indications for this donor lungs to go through EVLP? Basically, donors that have low donor PF ratio, so when it's less than 300. This assembles kind of the idea of an ARDS. So ARDS, it's considered a PF ratio less than 200, 300. So that's the same idea. Lungs that have a lot of pulmonary edema. If at the time of procurement, retrieval, there's bronchoscopic evidence of aspiration or infection. Donation after cardiac death. So during the course, we're going to go into the 2 specific type of donors, as I mentioned, but so they're donors from brain death and cardiac death. So donation after cardiac death, they are deemed to be a bit more higher risk. So we usually put them on the EVLP platform. And then there are more new indications for EVLP, like having positive HCV, so hepatitis C virus donors. And I'm going to go into this topic specifically to give you a really nice example. And just for you to have an idea of how this impacted the transplant program here in Toronto. So since the first lung transplant that happened in 1983 up to 2018, of course, the numbers of transplant growed crazy. increased really well. But what's important to point out here is that 2011 was when EVLP started in the institution. And what we can see clearly is that in 2011, the program did approximately 100 lung transplant per year. And after starting this EVLP, the program was able to do 200 lung transplants per year. So it basically doubled the transplant activity here in Toronto. Just by having this EVLP platform, doubled the number of lung transplant programs, because we were able to capture more and more donor lungs, put them on the platform, evaluate, and safely transplant into the patients. Whereas if you don't have the EVLP, you're just going to decline this donor organs, as I mentioned before, even before going to the donor site, let's say. And here it's just to explain that. So basically now our current practice in donor lung utilization, so that old idea that you have to decide once you have a donor offer, if you're going to retrieve this donor or not. And then you only have that cooler to preserve the lungs at 4 degrees. But now with ex vivo, you have an opportunity to actually get more of this lungs that you're not too sure if you should proceed. You put them on EVLP, and then you have another opportunity to assess. And this actually increased, as I said, to 60%, almost doubled our activity. So this is the new Toronto practice in donor utilization. And nowadays, so since 2011, here in Toronto and in other centers in the world, we've been doing a lot of research, a lot of basic science research around possible therapeutic treatments that could be performed during EVLP, right? So we can do really high dose antibiotic treatments to clear, let's say, a pneumonia process that could be happening in the donor lung. We can give inhaled agents like nitric oxide to improve the ventilation of these lungs, to open up the endothelial spaces. We can do gene therapy. So we can deliver gene therapy like interleukin therapies to improve the quality of the lungs. So this is heavily the basis of research that's been done here in Toronto in the last 10 years or so. And I want to just briefly go through a clinical case that happened that used the ex vivo platform to actually treat hepatitis C virus before transplantation. So really briefly, the story here is that the donor was a 60-year-old male, presented at the emergency department unresponsive with a clinical scenario compatible with a stroke. And the CT scan of the head revealed massive intracerebral hemorrhage. The donor had a smoking history of 40 pack years, quitting 6 months prior to his death, as well as a history of cocaine use. And the main problem here is that he was known to be positive for the hepatitis C virus since 2014, and he was not being treated. And this clinical case happened back in 2016, and hepatitis C virus donors were not used in transplant nowhere in the world. But here in Toronto, we had a patient, a 44-year-old man with a history of pulmonary fibrosis. He had previously underwent a left single lung transplantation 3 years prior to the admission. But unfortunately, he developed chronic lung allograft dysfunction. So basically, he rejected the graft that he received, the donor organ that he received. So he actually needed a retransplant. He was hepatitis C negative, and he was really ill in the hospital and really needing more oxygen, and he would probably die in the next few days. So then the team here got offered this hepatitis C positive donor. So what we decided to do was to actually put this donor lung full of hepatitis C into the EVLP platform and see if we could decrease the viral load to safely go on to transplantation. And that's what actually happened. And you can see here that, so this is at the beginning of EVLP, hour 0, and at the end of 6 hours. And what's it's showing are the HCV viral loads. So we can see that the EVLP platform allowed for a washout of the virus from the lung. And at the end of 6 hours of EVLP treatment, there was almost no virus. And what we can see here, the second graph on the right, is actually showing the HCV levels in the patient that received this organ. And we can see that after 6 weeks, the patient was negative for HCV. So this was quite an accomplishment. And this actually made us start different research around this topic of hepatitis C. And we actually published this paper here where we wanted to try to fully inactivate the hepatitis C virus in the donor organs. And what we did is that we used light therapies doing EVLP, because we know that ultraviolet C light is capable of killing hepatitis C virus. And you can see here in this video, this is an example of how we did it. And this is a clinical case. So we would put the organ on the EVLP platform and treat with this ultraviolet C. And then what happened here is that we were able to inactivate all of this virus that was in the lung. And we actually did a clinical trial with this technology, so EVLP plus the UVC light. And it was a really nice clinical trial. Patients didn't get hepatitis C. Some did, but the majority didn't. So it was really innovative, and it was a really interesting thing that happened in the field. And this is quite recent, the last 3-4 years. And really, just to end our time here, I just wanted to say that this ex vivo strategy is happening not only in lungs, right? Lung is, I think, the oldest and probably the most established one out there. But you can see here, this is a kidney being perfused. In the left here, a kidney being perfused, in the same idea of this ex vivo platform. Here in the bottom, you can see a liver being perfused. Here, I'm going to show you a video of a heart being perfused ex vivo. So it's quite nice. And the idea is quite the same, right? The idea is being able to capture more and more organs for transplantation, because the lack of donor organs is a major problem for any transplantation in anywhere in the world, right? So what we're doing here is really trying to get more and more organs to save more and more lives. So it's quite interesting. And you can see this is spread out through all the other organs too. So just to summarize, so the ex vivo lung perfusion can basically improve the organ assessment, repair injured organs from current donor pool, and create a donor pool not available before, like the example I just gave you of the hepatitis C virus donor, right? Maybe I can tell you an example of like an HIV patient. So for now, HIV patients are not considered donors, right? But maybe in the future, we will have a specific treatment that we can do on EVLP, and we'll be able to get this donors into the pool, and that will be really, really, really interesting. But this idea here, and it's already happening, is for the hepatitis C. But we can just think that like 5 years ago, we didn't even do this type of transplant. And now like there's a lot of donors with hepatitis C that we are capturing more and more, and we're able to save more and more lives. I think that's all that I had. I would encourage you all to join us in our lung transplant course. I think it will be really nice. This was just a taste of what we'll be talking about. We're going to go into details, talk about the nice studies we've been doing to really, again, I'm biased, but it's a really nice field, and I really invite you to join us. And I'm open to any questions you might have. I'm happy to answer them. Thank you very much.
Dr. Rafaela, thank you for being with us tonight. I'm sure the work you were doing in Toronto with another colleagues is further developing the possibilities to improve the lives of many patients. And now you are bringing with us this work to Brazil. So this is an honor for us.
For sure. Thank you very much. I appreciate a lot the invitation. I'm Brazilian, so I'm always happy to expand knowledge, to share what we've been doing. And I think most importantly, share that we're capable of doing all these things that might seem too much or too crazy, but I'm here. It's been 5 years and it's been quite a journey, but it's really nice. And I'm happy to share all of this with everyone and just inspire maybe a few people. I think that would be really nice already.
You inspire doctors and non-doctors. You're special.
Thank you.
Okay, so thank you very much.